Welcome to today's webinar, 100 Wasted Years, Overcoming Stigma and Bias in Opioid Treatment. This webinar is supported by the Illinois Public Health Institute, Chicago Department of Public Health, other partners, and our subject matter experts. We have some quick webinar housekeeping and logistics. So all participants will be muted. Any questions that you have, we have a Q&A feature, we have a chat feature. Feel free to use either of those to ask any questions throughout any period in the webinar, and we'll answer them at the Q&A session at the end. If you're unable to use the chat feature, please feel free to send me an email at this email address with any questions that you'd like to be submitted. And finally, stay on at the end for the Q&A and information about evaluation and CME approval. And I will pass it along to Alyssa Bassler, our CEO at IPHI.
Great, thank you so much, Samantha, and thank you to all of our presenters and partners and everyone who's joined this call, this webinar. We're very pleased to be able to offer this. I want to give just a little bit of background on what this, sort of the genesis of this project and what we're trying to achieve, and then we'll turn it over to Diana, Steve, and Jessica for the content. So IPHI, the Illinois Public Health Institute, our work is really to work through in collaboration with partners across various different sectors to improve the health of communities. And one of the groups that we work with a lot of hospitals to help them advance more community health and prevention. And we have been for the past 3 years working with and funded by the Chicago Department of Public Health to work with emergency departments to strengthen their ability to dispense naloxone to patients who are at risk of overdose, to initiate medication-assisted treatment in the emergency room with referrals to community-based providers for ongoing supportive care. We did some work as we were working on this in the first few years and learning some of the barriers. We did some work around policy change to make sure that there's reimbursement for this service as an add-on fee to the emergency department payment for emergency departments who provide this service. So we did some advocacy and policy work on that. And then we want to connect folks with opioid use disorder to immediate prescriptions and referrals via the new statewide MAR Now program, which makes it much easier for people to access care in and out of the emergency room. Next slide, please. So in addition to this webinar series, we also have a free program this summer to consult with our experts with emergency departments on achieving some or all of those goals that I just listed out. So for Chicago emergency departments, if you have if you want to have someone, one of our panelists here today, come and talk to your emergency team and talk about any of the things that you're seeing on this webinar, or how to develop workflows, or how to develop a program of treatment for opioid use disorder in the emergency department, treatment and referral, you can reach out to us and we can get you someone to come and do an overview, customized presentation, and even some additional one-on-one consultation to solve any specific or particular problems you have around developing policies or workflows, et cetera. Next slide. So I just want to mention that we are offering CMEs to physicians through the University of Illinois College of Medicine, and there'll be some information at the end of the webinar in terms of how to access and acquire those CMEs. Next slide. So we have 4 sessions. The first one was last Friday, just more of an overview of the challenge of meeting the opioid challenge in emergency departments and the sort of emerging standard of care for opioid use disorder treatment. in an emergency department. And then today we have the webinar you're here for. And then in July, we have two more webinars, one on like the very specific technical and clinical details that you need to know for doing an opioid treatment program in your emergency department. And then the last one will be focused on collaborating with partners, developing referrals approaches, how to be paid for through Medicaid to payment for this service, and so on. I will also add all of the webinars will be recorded. So if you missed last week's, we'll be able to share that with you. We're going to put them all together and package them so that it's not available right this minute, but we will be able to share all of these webinars sometime in the near future. Next slide. So I'd like to turn it over to our team of experts, and I'll let them introduce themselves. So I'm going to hand it off, I think, first to Jessica, and then we'll go from there. So thank you very much again for coming, and looking forward to listening to all of the great information today with you.
So actually, I think I will go first since Jessica's presenting today, so she can go right into her talk. But I'm Dr. Diana Batari. I'm the medical director for Controlled Substance Monitoring Team for Advocate Aurora Health. My background is addiction medicine, as well as pediatrics and integrative medicine. And clinically, I do pain care, integrative pain care. And I'm very proud to be a part of the subject matter experts for Illinois Public Health Institute. Steve?
Thank you. Steve Holtzford. I was an ER doctor for many years at Del Nor Hospital in Geneva, part of the Northwestern system. And 5 or 6 years ago, I became interested in addiction medicine and took the addiction boards through the practice pathway, which is available for a couple more years. And now I'm just doing addiction in a few different scenarios. It's just been incredibly fulfilling. And I'm happy to be part of this IPHI team to hopefully increase the level of care for patients struggling with substance use disorder in our EDs. Jess?
Hi, thanks everyone. My name is Jess Richardson. I am a family med, addiction med doc here in Chicago. I'm stationed currently on the west side of Chicago. I actually was born and raised here on the west side of Chicago. And so when I was growing up, I wanted to be a doctor for those that were near and around me. And so once I became a physician, that's exactly where I headed. And this subject, these patients are very near and dear to my heart. So let's go ahead and go to the next slide. So real quickly, an overview of our webinar. Last 2 weeks ago, we did an overview of the opioid challenge and how it affects the ED. Today, we're going to do overcoming stigma. And then the next 2 webinars led by Dr. Batari are going to be all the technical detail you need to know. So like 1, 2, 3, how to start buprenorphine, and then referral workflows and payments will be a last webinar. So please join all 4 or the next 2. That would be awesome. Today, we're going to go over just briefly about the opioid epidemic. We're going to go over stigma and understanding stigma and where stigma comes from, and then becoming familiar with OUD, MOUD, and health equity and what that entails. Next slide. So real brief. I know we've talked about this so many times, but just to review where we are right now within the opioid epidemic. Next slide. So this is from the statewide semi-annual opioid report. This is from February of this year. And as you can see from 2020 to 2022, the amount of OD deaths from opioids kind of is at, and the average is at a standstill. We have not gotten any better. We have not gotten any worse. We just kind of are not moving, which is a problem. And it's something that we as a community need to fix. And so I'm thankful that all of you are here today to help us to start to fix this issue, but we have the resources and we have the tools to do it. We just need to jump in and start and get it going. But this is where we are. We haven't really changed over the last 2 years. Next slide. And I love this slide. This just shows where our opioid epidemic is. When we hear about like the opioid epidemic, we think about the suburbanites or people who tend to take opioids via pill prescribing. But here in Chicago, and we're going to discuss the history of opioid use in Chicago, this doesn't affect the communities that we are taught it affects. It's affecting our west and our south sides. The zip code with the #1 overdose rate this year is in Austin. It's Garfield. So Garfield Park on the west side of Chicago has the highest rate of overdoses and overdose deaths. And as you can see, like the dark blue areas, so our west sides and our south sides, where our patients have many, many barriers to care, from decreased transportation to decreased financial means to unstable housing. Also then to have on top of that opioid use disorder that is not appropriately treated, and are experiencing these high rates of of overdose deaths. Next slide. So let's talk about stigma, because this is a huge part of how we treat our patients who present to us with opioid use disorder, and whether or not they're going to come into our building seeking help for opioid use disorder. When we meet someone or engage with them in a way that is stigmatic, it really decreases that person's sense of self or their sense of personhood. And it affects the way that they are treated. It affects their course of addiction, their chronic disease. So let's talk about stigma. Next slide. We're going to play some videos because patients say it best.
But I went in and I was asking them, did they have a chemical dependency ward? And the lady was so nasty, you know. Yeah, but our beds are full, honey. You just gonna have to come back some other time, you know. And it was hard enough for me to admit that, you know, that was the first time I went to the hospital admitting that I had a opioid problem. And she shut me down so fast. It made me feel so bad.
It's a huge barrier for anyone that's like right on the cusp that really wants to ask for help. I mean, that stigma, they're already dealing with a stigma within themselves of what are people thinking of me. But then when you actually see it, you see the difference in treatment. I mean, it's kind of shuts the door on your face. Like you're not very likely to ask for help that you need.
I could hear the nurses like talking and whispering to each other and stuff. And I guess from being outside on the ground, I had a dead cricket like in my armpit or something, and I could hear them whispering, like wondering if it was roaches. And then they kept asking me questions like, do you have roaches and bed bugs or lice and all this stuff that had nothing to and so I kept telling them no, and then when it was kind of like they didn't want to be bothered with me a little bit. I would try to ask questions, and I don't know, I kind of felt dismissed and less than, kind of.
But I went in and I was
barrier.
Next slide. I was muted. What these videos are showing is that this is not just something that we're gonna do modules on and learn about and think like, oh, does this really happen? No, the stigma is real and it is affecting our patients now today. And it really decreases or it burdens them to know that they're going to experience this different level of care from individuals, from medical providers that are supposed to help them in their time of need. And so let's get into kind of where the stigma came from and what we can do to decrease it in ourselves and in our work environments to make it so that our patients feel safe and feel welcome to walk into our emergency departments and into our clinics to seek help for opioid use disorder. So stigma is definition-wise, is a mark of shame or discredit, and it's conveyed by language and behavior that assigns shame or diminishment to the individual that you're speaking to. So not only our patients are hearing this, but they're also seeing it in our body language. And it really does, it disrupts the patient-provider relationship, and it disrupts that care that's provided. So when you're feeling stigmatized, you don't want to go into the place that's stigmatizing you. You don't want to be around those individuals. And so it's going to decrease your willingness to seek treatment. And it can negatively influence how other healthcare providers, if they're interacting with someone who is stigmatizing an individual, it will influence those other healthcare providers on how they also act towards that person. So it's just like a domino effect of stigmatization that we really need to stop. Next slide. So words are really, really important. This great quote says, if you want to care for something, you call it a flower. And if you want to kill something, you call it a weed. And this is important on why words matter when we're speaking about our patients, especially those with opioid use disorder. Next slide. So stigma in general, it conveys weakness or a character flaw or a moral failing, something like this is affecting you, but could never happen to someone like me, making a person feel less than, kind of like you'll be back, but you're not worth my time. And it misinterprets this idea of scarcity behavior, which is something we're going to touch upon a little bit later. Next slide. So this is a patient of mine, actually, that I sent from my family medicine clinic to be directly admitted to the hospital for, it was like liver cirrhosis, decompensation of liver cirrhosis. And when I went into her chart later to read what was happening in the hospital, this was from one of the consults. And this reads, patient is a 64-year-old female with a past medical history of polysubstance abuse, previous alcohol abuse, now sober, but with ongoing heroin abuse. HCV, who was admitted from family medicine clinic, given abdominal discomfort and ascites requiring paracentesis. This is really important because as medical providers, we often, before we even go to see a patient, we're going to read the chart. We don't just walk in blind into a room and say, hey, how are you? What's your name? How old are you? What are you doing here? We go and we look them up and we read their chart, we read their history, and we mentally prepare ourselves for what's to come before we even walk into a room. So when you're reading these words, especially if they're stigmatizing words, the image that we have of this person that we've never even met begins to form. And the idea that we have about their story and why they're here and what they will want from us is already forming before we even lay eyes on them. And so when we enter that room with all these preconceived notions that we've come up with just by reading their chart, the patient will see that. Our language will be based upon this image and the story that we've already made in our brains, and our body language and our actions and behaviors will all be they'll all be in line with what we have thought about them. And this patient in this first sentence was stigmatized 1, 2, 3, 4 times within the first half of this sentence. And so let's talk about which of these words are stigmatizing and what we can do to change that. Next slide. Again, this is important because how you read or how you discuss someone with another medical provider is going to set the course for the treatment plan and the care that patient is going to receive. So they did an actual trial on this, and they gave 2 groups of the same clinical scenario, but they named the patient in one group the substance abuser and the other a person with substance use disorder. And what they found was those who termed the patient substance abuser they were more likely to give punitive measures. So their treatment course was more punitive than those who were terming the person with a substance use disorder. So this is a problem, and it's something that we actively need to work against. Next slide. So words that are bad, or words not bad, bad is not the best term, words that are not appropriate and that convey stigma and things that we should change, like abuse. Instead of abuse, say use. So instead of someone with heroin abuse, someone with heroin use disorder or opioid use disorder, someone with, instead of alcohol abuse, someone with alcohol use disorder. Instead of an addict or a junkie, someone with substance use disorder. Instead of an alcoholic, again, alcohol use disorder. Instead of saying relapse, the patient relapsed, or the patient was sober, is no longer sober, return to use. This it helps you to see this person as this patient as a person with a chronic disease, rather as someone that we're judging, we're applying judgment to. So next slide. One of the things I like to say, like, you want to talk about patients in like first person terms. So we never call someone with diabetes like a sugar addict. We don't say that, or a sugar abuser, or a carbohydrate abuser. We don't say those words. We say this patient has diabetes. And that sets the table for us of, okay, we need to provide medication and counseling to help them control their sugar levels or their fasting glucose, however we want to term it. Someone with alcohol use disorder or opioid use disorder, if we say this is someone with a heroin addiction, we're now thinking about how can we stop their heroin addiction instead of treating their opioid use disorder and the challenges that come and the side effects and the withdrawal, the symptoms, the treating the symptoms that make opioid use disorder hard to overcome or hard to treat. So these are words that we want to change. Now, patients themselves will use words to describe themselves. They'll say, I'm an addict, or my urine will be clean, or my urine will be dirty. That's okay if a patient describes that of themselves, but we as medical providers should not use these words, and we should not use these words when we're charting, and we should not use these words when we're talking to other medical providers or other medical personnel about patients that we're seeing that come in with any substance use disorder. The next slides are going to be more words that we can replace. So next slide. We'll go through these more quickly. So instead of alcoholic and drunk, someone with alcohol use disorder, someone who misuses alcohol or engages in hazardous alcohol use. Next slide. Instead of dirty, so the patient's urine was dirty for marijuana, you want to say they tested positive. You want to say that their urine is positive for whatever substance it's positive for, or it's negative for whatever substance it's negative for. Just like we say a positive pregnancy test or a positive strep test. Something is either positive or negative, and then what we're referring to instead of saying dirty and clean. Next slide. Abuse, same thing. Abuse is associated with negative judgments and punishment. So instead we want to say misuse or alcohol use, used other than prescribed instead of the actual word abuse. Next slide. Some more, even MAT, instead of MAT, medication assisted treatment, we're trying now to gear towards MAR, medication assisted recovery, because the term recovery is less stigmatizing than the word treatment. Next slide. And when we're doing, the reason for doing this is to decrease the words that we use, is a step in offering evidence-based care in a way that decreases the barriers. By decreasing the stigma, we're decreasing that thought of a patient, the fear of a patient to enter into our doors and to seek help. So we want to practice non-stigmatizing language, which will help us practice non-punitive care and give us the ability to offer more and then to improve our access to care. Next slide. So where did this kind of stigma even come from? This is very important to know because for some reason, we're all walking around with this idea that we need to take punitive measures against people who are using illicit substances. Why do we do that? And in order to talk about that, we're going to need to talk about the war on drugs. So in 1968, the Nixon campaign started this war on drugs. And the Nixon's domestic police chief, John Ehrlichman, actually had an interview in 1994, which was it wasn't published until a couple of years ago, I want to say. And in it, he had this quote, and I'm going to say it directly. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So that was the start of the war on drugs. Nixon in 71 declared it public enemy number one. He passed the Comprehensive Drug Abuse Prevention and Control Act, and that put all drugs into an organized system based on addiction potential and medicinal use. And we still use that today. So this is when marijuana was placed into the Schedule I category, when methadone was placed into Schedule II, buprenorphine wasn't out yet, but this is where we're getting those schedules for our drugs. He also created the DEA. And this was to target production, distribution, and use of illicit drugs. War on drugs it died down, it quieted down for a moment, and then it reemerged in the 80s with Reagan. Reagan expanded the war on drugs, increasing the number of people who were in prison for nonviolent drug offenses. And First Lady Nancy Reagan started her campaign of Just Say No to Drugs. She suggested that children who are facing peer pressure to try drugs should just say no. And that became the anti-drug slogan. This campaign really built a public fear about drugs. In 1986, Reagan enacted the Anti-Abuse Act of 1986. And this enacted 100-fold greater sentencing disparity for cocaine base, which is crack, water-soluble cocaine base, which is crack, versus powder cocaine. And in 2006, 5 grams of crack carried a minimum of a 5-year sentence in federal prison, while 500 grams of powder cocaine had the same sentencing. Why this is important is because crack is the cheaper version. And I'm going to date myself, but back in Whitney Houston's time, Whitney Houston was known for saying, I don't do that, crack is whack, because crack was the cheaper and cocaine was the more expensive version of this drug. And so the crack, because of its, cost, is going to be found in our communities where they have a harder time assessing or having financial stability. And so they're going to go for things that they can afford, which would be crack instead of cocaine. And this tended to be our minoritized population. So our Black and brown populations were getting hit with these tougher jail sentences for the same substance. So as you can see on this graph here, Nixon declared a war on drugs in 71, and then the male incarceration rate just skyrocketed. And this is between 1925 and 2016. Next slide. So the reason why this is very, very important is that the war on drugs really hit our Black and brown communities. It created this idea for society that drugs are very, very bad. Illicit drugs are bad. And the people who use illicit drugs need to be punished. And those people that were punished were our minoritized individuals. And not were, they still are. So we were slammed with these commercials and these posters and these slogans and these phrases like crack is whack. And it all was geared, the punishments that were happening were our Black and brown individuals, our Black and brown men mostly. In 1972, 161 out of 100,000 citizens were incarcerated. And by 2007, that number peaked to 767 out of 100,000. And then it dipped a little bit in 2021. It's now 639 per 100,000. But it's still the rate of incarceration skyrocketed, and Black people made up more than a quarter of nearly 1.6 million people that were arrested in violation of drug laws in 2019. This is from the Department of Justice. So they made up a quarter of the people who were arrested for violation of drug laws, yet they only made up 13.4% of US population. And Black and Latino individuals, they're more likely to be characterized as criminals and drug users by the media. And then as our opioid epidemic started to shift towards overprescriptions, we didn't get that characterization. So when we started to get a shift towards our suburbanites who are addicted to Oxycontin, they were consistently portrayed as victims of overprescribing or people struggling with real or existential pain, while our Black and brown citizens were described as criminals and drug users. Next slide. So it wasn't just Reagan. It wasn't just Nixon. Actually, there are many laws, policies, and procedures. I have started to talk about our Black and brown individuals, our minoritized communities, and what I'm talking about is racism. And when I say this word racism, I like to start it by talking about the definition of racism, because I argue that we are all racist. We all have racist behaviors and racist actions, and we have to work against them. So for me to say that or to make that claim, I like to first define what it is that I'm claiming. So I like actually this, there's a definition by Kendi that says racism is actually the culmination or I'm sorry, I didn't have it pulled up, Samantha. Racism is the effect of policies and procedures that create an inequity between two groups of individuals. So any policy, procedure, law, regulation that creates this uneven footing and an inequity between two groups of people, that is a racist act or racist behavior. So anytime that we are enforcing these policies or procedures, or we are enacting these policies and procedures, or we are agreeing with policies and procedures that promote unequal footing, which is inequity, then we are promoting a racist act. And so in order to undo that, we need to actively demote or go against these policies and procedures. And so right now I'm going to talk a little bit about the racial disparities in drug policies and addiction treatments in our country's history. It starts with the Opium Den Ordinance. This was the nation's first anti-drug law, and it banned opium dens in San Francisco. This was specifically directed at Chinese immigrants. So they created this story, and by they, I mean the people that created this policy, that the use of opium by Chinese persons in opium dens was causing a problem for society. And when they were promoting this law, they used words such as smugglers, gamblers, and prostitutes, and spread this story that these individuals who are using opium dens were considered to be morally bankrupting others. And so this policy, which was going to ban opium dens, would have created an unequal footing between Chinese immigrants and those who are not of Chinese origin, who are immigrants or not, or citizens of this country. So that is a racist policy. We go then to the ban of marijuana in 1914. This followed an increase in Mexican immigration following the Mexican Revolution in 1910. And based on the narrative that was given, the crimes and violence that were being seen in El Paso, Texas, were resulting from smoking marijuana. So again, we're creating a policy against a specific group of people for a drug or an illicit substance, and creating punitive measures to be taken against them. In 1914, we also had the Harrison Narcotics Tax Act. This was a special tax that put upon all persons who produce, import, manufacture, compound, deal in, dispense, sell, distribute, or give away opium or cocoa leaves, their salts, derivatives, or preparations, and for other purposes. So what this did was this banned doctors from prescribing drugs that were opioid based. So and then it didn't stop there. We had the Controlled Substances Act of 1970, which we're going to talk about. And then we already talked about the 1986 Anti-Drug Abuse Act. That's what around this time, like we're having this skyrocketing of minoritized individuals who are being jailed for marijuana and for cocaine. And then we have all the way up until 2020, when we actually had the X waiver introduced for buprenorphine. And then the introduction of the X waiver did increase MOUD, like it did, because before this time we only really we're using methadone and naltrexone, and then providing more opportunity, like increasing access to buprenorphine, was what the Drug Addiction Treatment Act of 2020 was done for. That's not it. It's not 2020. It's 2000. It's 2000. I don't know why it says 2020. I'm sorry, it's 2000. It's data 2000. So that increasing access to buprenorphine was great. However, it was marketed towards suburban individuals or highly affluent individuals who could afford to pay for buprenorphine, and then it was provided by doctors in those communities, and then our other communities received methadone. So we're going to talk about that more, but these are all policies and procedures that were implemented in our country that created these unequal footings when it comes to drug use between our minoritized populations and our non-minoritized populations. And then we used these punitive measures, and we were taught to use these punitive measures and to believe that they were necessary to enact upon these people that use drugs. Next slide. So ASAM in 2021, which is the American Society of Addiction Medicine, published a policy statement on advancing racial justice in addiction medicine. And I quote from their policy statement: explicit racism directed against immigrant, Asian, and Hispanic Latinx labor, Black men, and concern about women stolen into white slavery, and it ushered in a period that prioritized policing over public health. So we need to go against this. Racism really is ingrained into the way that we practice medicine, and it's ingrained into the way that we practice addiction medicine, treating people who have substance use disorders. And it really has cloaked how we see these individuals who come in with opioid use disorder or alcohol use disorder or benzo use disorder, and how we speak to them and how we treat them and how we think they should be treated. All of it has to do with how we came up in the society. And I don't want to place blame on anyone, but this is just how we were raised. But because we know how wrong this is, we have to counteract it. And so we have to do things like starting with anti-stigmatic language, and advocating for our patients. And another little tangent I want to go off on is opioid use, medications for opioid use disorder, the medications itself, because we talk a lot about buprenorphine, but we don't talk about why there's such a distinction between methadone and buprenorphine. And we have to know where that came from so that we can counteract it. I don't have a slide for this, but it's something that really needs to be spoken about. So methadone actually was introduced in a pilot study as a treatment for OUD in 1965, and then it was approved for MOUD in 1972. And it's highly, highly regulated. It's one of the, I think it is the most regulated drug in our country. So first, the first regulation is by the FDA for manufacturing, labeling, and dispensing. Then it's got a second regulation by the DEA for production, distribution, and dispensing. Then, and the DEA regulation is of course to prevent diversion and illicit use. But then it's got a third regulation on top of that by the Department of Health and Human Services to say who can treat opiate addiction, including restricting it to hospital pharmacies and to physicians that are registered with both the FDA and the DEA and are only dispensing it in a treatment program. So those outpatient treatment programs, the OTPs, this is why those are the only ones who can give out methadone, because that's the third regulation placed on methadone. And then often it's further regulated by state governments and counties. So there are like 4, maybe 5 tiers of regulations on methadone and who can get it and when they can get it and where they can get it. Like the barriers placed on these individuals who are seeking treatment for opioid use disorder are just stacked one on top of the other, making it very, very difficult to get to. And methadone clinics, most of them are actually in Black and brown communities. I was trying to, the CDPH has an opioid dashboard, and on it is a map of Chicago and where these clinics are. And I tried to screenshot it, but it was way too big. But essentially the OTP clinics, there are like, I want to say 4 or 5 on the north side. There are like 7 to 9 on the west side, and there's like 14 on the south side. So north side, there's like 4, and there's 14 on the south side. So they're clustered on the west and south sides. And the reason for that is because all the regulations and the stigma that went with methadone and who's being treated for methadone and the actual like dispensing of methadone is so punitive, those clinics were just pushed into our minoritized communities. So patients who are seeking treatment, they're going to go and they don't have access to transportation. They don't have access to finances to get an Uber. They don't have jobs that are going to let them like go take off to go to a doctor's appointment. They need to go get their medicine early in the morning. These individuals are going to go to the closest. They have all these barriers already, so they're going to go to the closest place they can, which ends up being a methadone clinic, which is a highly stigmatized treatment in our medical community. And so that on top of the stigma they get as having opioid use disorder, on top of the stigma they get for being minoritized, you can see how this just decreases their ability to even seek care. So when the Data 2000 waiver lifted the ban on opioid prescriptions, that allowed just, all providers to be able to prescribe buprenorphine, but it kept the methadone system restricted to the DEA. So methadone is a Schedule 2, buprenorphine is a Schedule 3, and BT dubs, marijuana is still a Schedule 1. Buprenorphine, the data waiver did have that 8-hour course. Thank God the waiver is gone, but that also was a barrier to care because providers who often are in our minoritized communities are like at federal qualified health centers who are not given time to do things. They're not given like approved time to do an 8-hour course. They have to do that on their own. So that was another barrier. So there are multiple barriers to care to receiving methadone versus buprenorphine. And in 2006, a study showed that 91% of patients using buprenorphine as maintenance were white, whereas 53% that were using methadone were white. 56% of patients who were using buprenorphine were college educated, whereas 19% of patients on methadone were college education. And then that persisted into a 2013 study, and it persisted into a 2020 JAMA article that showed between 2018 and 2019, methadone clinics were significantly more likely to be located in highly segregated Black and Hispanic counties, while facilities providing buprenorphine were more likely to be located in white counties. So this is something that's happening. It was happening up until the waiver was gone, right? So now anyone could prescribe. But before that, so before January, a majority of our communities that were giving buprenorphine are in our white communities, whereas our Black and brown communities are mostly given methadone. So the racial discrimination between MOUD treatments alone is staggering. And it's something that now we don't have a waiver, and these patients who are suffering from OUD are more like are in our Black and Brown communities. So they're going to show up into our EDs that are serving those communities to be able to provide them with access to treatment that would provide them with a freedom of time, like not having to dose between 6 and 8 a.m., not having to dose every day while having a urine that's negative for opioids or negative for any illicit substances before they can take home medication, freeing them from that system so that they can go seek whatever it is that they want to seek in their life. That's important. So really, we do need to counteract these policies and procedures that were laid down that were causing these inequities within our community. And we're given that opportunity now. So this is how we can help. Next slide. So there is evidence for systemic bias. We've talked about it. It's there. It was there in the before. It was there in the early 1900s. It was there. It got worse in the 70s, and it's here today. The data is there. We just need to work to reverse it. There's a lot of stress and burden on our marginalized communities. There's a lot of systemic bias in OUD care itself, and we need to overwork that. The ASAM, when they published that Advancing Racial Justice in Addiction Medicine, they're recommending a more diverse addiction treatment workforce that advocates for policies that result in more equitable access to prevention, early intervention, and treatment of substance use disorder. And it calls on addiction medicine professionals, all of us, to examine our own biases. Next slide. So we need to throw out, the dirty bathwater, so that treatment should be rooted in punitive measures. That comes from the war on drugs. We got to let that go. We need to realize that our judgment, our judgmental language, our judgmental behaviors are stemming from all these ideas we have about people who use drugs. We need to let go of that. Next slide. We need to not implement or not believe that incarceration is the primary consequence. Rather, we need to believe that treatment for substance use disorder should be the primary consequence. We need to stop saying that these individuals have a moral failing, or that they are criminals that need to be punished for what they are doing. They are adults who are suffering from a chronic disease. Substance use disorder is a chronic disease, and it should be treated as such. And when patients are coming to us for treatment of their chronic disease, we need to provide it to them instead of doing harm by stigmatizing them and judging them and giving them punitive treatment instead of evidence-based treatment. Next slide. So let's talk about what our patients actually, what they experience when they walk through our doors. Next slide. So I often say that I think the most courageous patient that I ever have come across will be a Black man in his 60s or 70s who is coming into the clinic for treatment of his opioid use disorder. And I say that because now, with our education on the war of drugs, Black men who in their 60s and 70s were in their young prime during this war on drugs have likely been incarcerated for drug use and now have to walk into a clinic or an ER. And if they're walking into one of my federally qualified health centers or an ER, the first person they're going to meet is a security guard. And that security guard may or may not be armed. And they have to walk past this person who likely in the past, individuals who are armed and who are within our police forces have done harm to them. They have to walk past that and go and admit to someone that I'm using an illegal substance that before I have been harassed about, I have been jailed for, I have been incarcerated for, or I have been dealt with poorly because of. I'm going to admit it to you and I need treatment for it. That takes a lot of courage to walk into a building and say that. And that's something that we need to recognize when they show up, that they had to muster up the courage to even walk into our doors and then admit that what they're doing is wrong, and not that what they're doing is wrong to them and that they want help. We have to be able to say, okay, come in. If you're here, I'm here. I will meet you where you are, and I can help here. Next slide. Like I said, we have to realize from Black Americans, this says 2011 to 2016. This is still true today. They have the highest increase in overdose death rate. They are the ones taking fentanyl. They are the ones that are dying from fentanyl the most. And all of this, a lot of this, and a lot of the way we think about this has to do with the ways our communities have been treated, the barriers that have been placed against them, and the punitive measures that have been taken against them. Next slide. So we also have to recall that as providers, we have major biases that include the way we treat our minoritized patients in general. So we are less likely to prescribe opioids for pain than white patients. We are less likely, we do not give the same level of treatment for our Black patients as we do for our white patients. And a lot of that has to do with the systemic racism that's embedded in medicine itself. So we have to recognize that bias on top of our bias towards substance use disorders and opioid use disorders. Next slide. Well, the one thing I did also want to say about that is we also have to realize that we have been taught that this opioid epidemic is from pill prescribing and over prescribing of opioid medicines. That's not true for our minoritized patients. Our minoritized patients have been having opioids in their lives for years. The average patient for me is a Black male that is 60 or 70. So this isn't from over prescribing opioid pills. These patients typically start using heroin when they are 14 or 15 years old, and they are still using today. So this is an old problem that is deeply rooted in our minoritized communities. And just now we are acknowledging that it has been there and that we have been mistreating it. On top of that, we need to recognize that our patients who are minoritized have many other barriers due to systemic racism that causes difficulties with them getting to a clinic or to an ER, including not having money to get in a car, or not having money for a car, not having money for a bus pass, not having money for an L pass like the MetroCard, not having food, or having to decide whether they're going to pay for medicine or pay for food, pay for medicine or pay for their light bill, not having the access to education. All of these issues create huge barriers for our patients, and then we're placing more barriers on top. So we have to keep all of that in mind when we meet these patients in our ERs. Next slide. We also have to remember that I talked previously about the scarcity behavior. People, their mind functions differently. Their priorities change if they're in an environment of scarcity. So like I said, if a patient is concerned about whether they're going to be able to keep their lights on this week, or whether they're going to be able to keep their heat on and it's Christmas time, or whether they're going to be able to feed their children and their mother because they live in a multi-generational home instead of paying for their medicine. The way that they act and the way that they behave is going to be very different than the remainder of us who do not have scarcity behavior. And if we did have scarcity placed upon us, we would act very similar. And we need to recognize that and provide humility for patients who are behaving that way, because it's a lot to have to make those kind of decisions, put your health second so that you can put the lives of those or the lives of your dependents before. That's something that we need to continually keep in the front of our minds. Next slide. So remember that substance use has been there. It has been there for generations in our minoritized communities. This is nothing new to them. What also is not new to them is the fear of legal consequences. The war on drugs definitely made sure of that. They are going to get arrested. They are going to get jailed. They also are more likely to have DCFS called on them. So they're less likely to tell you they have children at home because they're afraid you're going to call DCFS and they're going to lose their kids. In the communities themselves, substance use disorder is seen as a weakness, not as a disease. So their own community is telling them they're weak. They don't need us doing the same. they don't need the extra stereotyping or the extra stigma. They need us to be culturally responsible and be culturally respected or respectful for them. They deserve cultural respect. And a lot of that had to do with a lot of what we are seeing can be decreased by implementing buprenorphine in communities that weren't allowed to have it before. And that's where we are now, and doing that in a way that does not continue this journey of stigma that these patients have been through. Next slide. So seek to understand them, know their community, know where they come from, where they've been, what they have seen, know what it took to get them to you, and then check yourself before you treat them. Next slide. So let's go ahead and play this video.
With the Suboxone, that groove is gone. I don't have that, is it OCD? When you keep doing the same thing over and over and over again, like hand washing?
Yes. Yes.
Like that's what I told Cynthia. It was like with the Suboxone, it got rid of that groove in my brain. Methadone hadn't done that. So this works for me very well.
As we start to decrease stigma and decreasing that language, we're going to begin to normalize treatment for opioid use disorder, like we normalize treatment for hypertension and we normalize treatment for diabetes. It all just becomes another chronic disease that we are appropriately treating with evidence-based care. And our patients are going to be able to tell us why it's working for them and how it's helping them to live a life that they've wanted to live. Next slide.
With the Suboxone, that groove.
So in our EDs, when our patients come, we want to make sure that they feel welcome and they feel as a complete individual and they feel cared for. And then we can help to induct them and then help to send them off to another welcoming provider that will continue to provide this care, hopefully in a non-stigmatizing environment. Next slide. And then we can talk about what happens when we do it right.
Know someone in their lives who maybe parties a little too hard, or if they're not a full-on drug addict, is kind of on that edge, and that we're all just good people who do bad things, and I think we deserve just as much compassion as someone who had something done to them, as opposed to us doing something to ourselves. Know someone in their lives
I would also
who
like
maybe
to add
parties a little
for
too hard.
them to remember that we're people too, because I think a lot of times people with addiction disorders are put in this category of less than and treated a little bit less than human, and we're people too. Yeah.
First of all, there were people, and we're not bad. We just made bad choices. And I think that's real important. It's important that people don't look down on you. You feel bad enough already. And when somebody, it might be a tone of voice or something, they say, maybe I'm overly sensitive, but I don't think so. But they should know that we're people and we have all kind of talents and stuff. We're not just junkies. There's more to us than our addiction.
Just to be patient, treat them like a human, you know, understand where that they're coming from.
I couldn't really say it any better myself, so I'm just going to leave it there. And I'm going to pass it back to you, Samantha. Thanks for your time today.
Really, really appreciate that really excellent presentation. I think we have some time for Q&A, Samantha, if people want to put some questions in the Q&A it's available down at the bottom.
Thank you. And I think we had one question come in a little bit earlier, and that question says, sorry, I'm reading it. Based on Chicago specifically, are there any particular statistics other than what you've shown that can prove to emergency departments that the South and West Side and predominantly Black communities are most impacted by opioid use disorder and the criminalization of it?
Yeah, if a CDPH there's a CDPH opioid dashboard, which I think is only updated to 2021, but that one is heavily, like, they have the OD rates per zip code, and it's the highest one is in Garfield Park. And you can go through and just look and see these are EMS reported OD rates. I don't really know how much more you need than to see that. And then if you ever look at any of the graphs for any of like the social determinants of health, so lack of transportation, lack of housing caused by redlining, food disparities, even just like by insurance types or by police activity, you can see that it's on the West and South sides. It's where you have our BIPOC communities. Those are your more heavily policed areas. And I don't have the statistics for like the Cook County Jail, but Cook County Jail, I think, is majority, like the one on Cermak and 26 in California. That jail is majority, it's majority BIPOC, but I don't have those stats in my head. But 26 in California serves like the Cook County. It's Cook County zip codes go there, if anyone else has any other data that they know of. But CDC also has, and per CDC data, Cook County itself was the number 2 had the number 2 overdose rate in 2020, which is terrifying. And that's in the whole country.
Another question we had coming in was, how do we on an individual level combat racism related to this topic in our emergency departments?
The first one is the easiest one is to correct language. That's the easiest one, is to say, just like we do with pronouns and with gender affirming care, you do the same thing. Like if someone says this patient has substance abuse, say, okay, and correct and say that we should use the term substance use. Stand up for those patients, be their advocate, because they often are there alone. They don't have the words or the knowledge to advocate for themselves. So even to say to a doc who's about to discharge, if you're even a nursing staff or a social worker, hey, I noticed that this person has a history of opioid use disorder. Would it be possible to give them Narcan on the way out? Would it be possible to give them the MAR-Now number? Help to bring it to our attention if we happen to miss it. We have to work as a team to advocate for those who can't advocate for themselves.
So do we have any other questions for Dr. Richardson today?
Okay, thanks.
Okay, I am not seeing any other questions, just a clapping emoji, which is great. So in our last minute then here, for our folks who are going to be getting CME credit, those are physicians, as Alyssa noted earlier, you are able to get CME credits if you're a physician through the UIC College of Medicine. To do that, please use this link, and we'll also drop that link in the chat. And the way that you do that, you either log in, register as a new user, you use the enrollment key webinar 2, I apologize, that should say webinar 2, and complete the evaluation form, and then you will get a certificate of completion that looks like this here, which means that 1 hour of this webinar, this one webinar, equals to 1 credit. And we have 4 webinars, so the next 2 webinars, you can also receive 2 more credits going towards this requirement for licensure. And if anybody else has any other questions other than that, our next 2 webinars, we have a webinar Friday, July 14th. This webinar will feature Dr. Batari talking about all the technical detail you need to know, dosing, risk, readiness, other technical questions. And on Tuesday, July 25th, Dr. Batari will also be talking about successful collaboration, referral workflows, payment, all of those wonderful things that you need to know. We look forward to seeing you at those 2 webinars as well. It's the same website to register for those 2. They're at the same time, 12 p.m. Central to 1 p.m. Central. So if you have any questions there, feel free to send me an email at samantha.lasky@IPHI Online. And thank you everyone so much for participating in today's webinar.
Thanks, everyone. I'll add my thanks to that. This was fantastic. So really appreciate everyone's attention and participation. Have a great weekend. It's Friday. Yay.